Welcome, and thank you for joining us today. My name is Ellen Wilson, and I'll be the moderator for this expert briefing for the media, which is hosted by the Johns Hopkins Bloomberg School of Public Health. Today's experts will discuss vaccines and their purpose, effectiveness, and safety. I'd like to briefly introduce our speakers. William Moss is a professor in the departments of epidemiology, international health, and molecular microbiology and immunology at the Johns Hopkins Bloomberg School of Public Health, and executive director of the Bloomberg School's International Vaccine Access Center. Anna Durbin is a professor in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. We will have time for questions following our speakers' remarks. We will take some that have been submitted in advance of the briefing and some from the Zoom chat. If you have a question, please enter it in the Zoom chat addressed to panelists and hosts. Please enter your name, media outlet, and question. We hope to cover as many as possible. Please note that participants are welcome to use images, video, or quotes directly from the briefing, and that the content is for immediate release. Participants will be muted during this briefing and it will be recorded. Let's go ahead and start. Dr. Moss, can you give us an update on the measles outbreak in the United States and discuss the vaccination status of those patients who contracted measles?
Yes, thank you, Ellen, and it's wonderful to have this opportunity to speak about vaccines. So what we know about the measles outbreak here in the United States is that it's growing. The Center for Disease Control and Prevention updates their data reporting on Fridays. And so they last updated their numbers on March 14th. And at that time, 301 confirmed cases were reported across 15 jurisdictions here in the United States. But we know the true number is higher. Just yesterday, the states of Texas and New Mexico updated their reported numbers. Texas reported 279, New Mexico 38, so for a total of 317 cases just in those two states. So the outbreak is continuing to expand and increase. Most of the cases here in the United States have been associated with these outbreaks, but we continue to have importations from countries outside the United States. We had a recent example of this here in Maryland with an infant who entered the country with measles. These cases encompass a wide age range across all ages, with 1/3 of the cases, according to the CDC data, younger than 5 years of age, but 42% of cases in the age group of 5 years to 19 years of age. I think what's very striking, Ellen, is that 95% of the cases confirmed and reported by the CDC are either unvaccinated or have unknown measles vaccination status. And this should be a very clear message that measles vaccination is what will prevent this outbreak from spreading and prevent new outbreaks. Only 3% of the cases with a measles vaccine history reported having received 1 dose, and 2% having received 2 doses. And this is very much in line with what we expect. We expect that about 93 to 95% of people will be protected after a single dose of measles vaccine, and up to 97, 98% following that second dose. And I just want to make clear that that second dose is not considered a booster dose. It's really to immunize those who are not protected after the first dose. So again, vaccination is the way to stop this outbreak and prevent future outbreaks. What's striking to me is that 17%, according to CDC data, of cases have been hospitalized, with the highest proportion in children younger than 5 years of age. We would expect that, about 25%, and there have been 2 deaths reported in association with this outbreak. To put this current outbreak in the context of prior measles outbreaks here in the United States, we had 285 cases, confirmed cases reported last year in 2024. So we've already well exceeded that total. Only 59 cases were reported in 2023. But we did have 1,274 cases here in the United States in 2019, and that was a big year for measles globally. We had a global measles resurgence, and we saw that reflected in the imported cases and outbreaks here in the United States. That outbreak in 2019 was largely fueled by a large outbreak of over 900 cases in New York City and New York State in an Orthodox Jewish community. And we had another large outbreak here in the United States in 2014 in an Amish community in Ohio with 383 cases. So what is striking about this current outbreak, is the speed at which it's expanding and increasing. It's hard to predict what's going to happen. There are two conditions for measles outbreaks. You have a susceptible community, a group of susceptible people, and you have an infectious person enter that. I like to think of this as like a forest fire with sparks spreading out. And if those sparks land in a community with low vaccine coverage, we're going to see a larger measles outbreak. If it lands in a community with a high vaccine coverage, we may only see one or a few cases. And so we are going to see continued spread of these outbreaks here in the United States. And we're also going to see continued importations from other parts of the world, because we're seeing measles outbreaks in all regions of the world, and will continue to be at risk here in the United States with larger and more frequent outbreaks, particularly in communities with low vaccine coverage.
Great. Thank you so much. Very helpful. Now, a question for you, Dr. Durbin. Vaccines have been around for so long that many of today's parents might not be familiar with the diseases vaccines are meant to prevent. Can you tell us about some of the major diseases that have been all but wiped out by vaccines in the US?
Absolutely. And thank you, Ellen, for having me today. I like to say that vaccines really are a victim of their own success. The reason parents aren't familiar with these diseases is because vaccines have been so effective in controlling them and preventing children from becoming ill and dying. One virus, the smallpox virus, has been completely eradicated from the earth, and this is completely due to vaccination. We no longer have to worry about smallpox, which was a devastating illness that killed nearly 30% of people who were infected. We know just since vaccines have been introduced in the past 50 years, they've saved the lives of more than 150 million children, which is remarkable. They've reduced the incidence of diphtheria, measles, mumps, and polio by more than 99% in the United States. However, we know, just as Bill has just described, that lower vaccine coverage due to vaccine hesitancy, these disease outbreaks can come back, such as we're seeing in Texas. I remember my mom telling me stories about how when she was a girl, she couldn't go to the swimming pool in the summer because of polio outbreaks. And how even when I was growing up and when I travel internationally, I see people with evidence of past polio infection, people with smaller leg, for instance, on one side than the other due to the traditional withered limb of polio. And I'm sure many others have seen the recount that I saw in the news associated with this measles outbreak, the quote from Roald Dahl about his daughter, how he was reading to her and she had been sick for about a week or so and seemed to be getting better. And as he was reading to her, he noticed that her hand was moving funny and that she just couldn't seem to put her words around. And she died within 24 hours from that. And that was due to measles. So I think because measles have been so successful in reducing the incidence of these diseases and certainly reducing serious complications and death, people forget about them. They don't realize how dangerous these illnesses really are. I can give another example of the Hep B vaccine that came out just as I was starting my early medical training. We used to have so many cases of deafness due to meningitis caused by Haemophilus B. When the vaccine came out, those cases of Haemophilus B, influenza, meningitis went to almost nothing. And we don't see the devastating effects of that. So, nobody wants to see these diseases come back. And that's why vaccination is so important. We just don't need the vaccines. We need people to get vaccinated.
Great. Thank you so much. Dr. Durbin. Now we will take additional questions. And a reminder, if you have a question, please enter it in the Zoom chat with your name, media outlet question, and to whom you'd like to address your question. Here's a question from Richard Payerchin with Medical Economics, MJH Life Sciences, for you, Dr. Durbin. What advice would you share with primary care physicians to overcome vaccine hesitancy with their patients?
That's a great question. And I think what we have seen time and time again, it's building trust. It may not be a decision that can be made in one office visit, but it's really what we found time and time again is that people go to sources that they trust for advice and for information. And so really building up that trust with the patient, having discussions, asking the patient what their concerns are and really listening to what those concerns are and having that discussion and building on it with each subsequent visit. It may, as I said, you may not change minds in one visit, but it's really important to have a discussion, to be willing to listen, to hear people's concerns and try to address those concerns as honestly as you can and in a way that the person can understand.
Great, thank you. Here's a question from freelance journalist Deborah Lynn Blumberg for you, Dr. Moss. Many adults are now getting their measles titers checked to make sure they still have immunity after childhood vaccination. Do you anticipate a need for this type of check safeguarding with other diseases as well? And if so, for which ones?
Yes, this is a very interesting question, and the short answer is I don't see kind of further expansion of testing for antibody levels for other pathogens, and I'll explain why it's a little tricky. So the idea behind that is that there's what we call waning immunity, and with measles of vaccine, particularly individuals who receive 2 doses, if they've responded, if they're part of that 97, 98%, the evidence suggests that they're really protected for life. There is some decrease in antibody levels over time, but I'll say that, having someone's antibody levels tested again for antibodies to measles virus can be tricky to interpret because many of the commercially available assays that are used in commercial laboratories are not sensitive enough at low levels of antibodies, and so may misclassify an individual as being antibody negative when they really have low levels of antibodies. And those individuals, upon re-exposure, if they're exposed to measles virus, are going to have what we call a memory immune response. And so they will have, an important rapid immune response, protective immune response against measles virus. And if they do get measles, they're going to have a much milder infection or course of disease. There are other vaccines, for example, tetanus or diphtheria, where we know that there is more waning of immunity. And in those situations, what we recommend is that people get a booster dose of the vaccine, what we call Tdap, tetanus, diphtheria, and acellular pertussis vaccine. And people don't need to check their antibody levels prior to getting such a booster dose. I guess in short, there are different reasons why we give multiple doses of vaccines. For measles vaccine, as I said, that second dose is really to immunize those who don't respond to the first dose. For diphtheria, tetanus, pertussis, it's because there is waning immunity, so we do give a booster dose. And then, for example, for influenza vaccine or even our COVID vaccines, it's because the virus is changing year to year or over time. And so we give new vaccines for that. So the short answer is I do not foresee a future where we're going to be measuring antibody levels across different pathogens.
Great. Thank you. And sticking with measles, this is from the Dallas Morning News for Dr. Moss from Emily Brindley. What factors determine how long a measles outbreak lasts, how large an outbreak becomes? And then the second question is, during the current measles outbreak in Texas, she's seen a lot of talk about alternative therapies, including amongst medical doctors. Is this a newish trend as vaccine skeptical people seek out alternatives, or have people always talked about alternatives?
Yes, these are two, very important questions. So with regard to, trying to predict or forecast the size of a measles outbreak, in some ways it's rather straightforward. It's really the proportion of the population that's susceptible to measles, so we could say unvaccinated against measles, and their contact rates, how frequently they come into contact with each other. I guess the third component there is the probability of an infectious individual entering that community. So it can be in reality hard to predict, but we can what we say, model measles outbreaks very easily, and straightforwardly by understanding what proportion of the population is susceptible, their contact patterns, are they gathering in schools or other kind of events where people are coming into close contact with each other to enable transmission of measles virus? And then the risk or probability of someone entering that community who's actually infectious against measles. And this is what we're seeing in West Texas, in the Mennonite community there, with low vaccination coverage down in the low 80s, 80%, a tight-knit community, people coming into contact with each other, and then an infectious person entered and sparked this large outbreak. With regard to alternative therapies, I think, this has been around for a long time. This is not new at all. But I think it's I'm concerned about is that these alternative therapies are being promoted, particularly through the federal government, when we know the answer is very clear here. It's vaccination that prevents infection. It's vaccination that's going to stop these outbreaks. These alternative therapies, first of all, none of them will prevent infection with measles virus. It is true that children who have underlying undernutrition or vitamin A deficiency will benefit from vitamin A supplementation if they are ill with measles. And the World Health Organization recommends vitamin A supplementation, but it's a very controlled dose. It's just 2 doses. Taking cod liver oil or other types of vitamin A can actually be more dangerous because of excess vitamin A can cause toxicity.
Great, thank you. We're sticking with measles. Another one for you, Dr. Moss. This is from Julie Steenhuisen with Reuters. Are we at risk in the United States of losing our measles elimination status? And what is
Yes.
the threshold mechanism for that?
Yes, that's a really interesting question. And so it's quite interesting. The definition of measles elimination in a country, in a region like the Americas, the region of the Americas, is that there is not sustained endemic transmission of measles virus for 12 months or more. So there's a somewhat arbitrary cutoff of 12 months, a 1-year period. So if a country that has achieved measles elimination by reducing the duration of its outbreaks to less than 12 months, then has an outbreak that extends for greater than 12 months, that country will lose its elimination status. And so the United States came very close to losing its elimination status. Well, I'll first say, measles elimination was declared in the United States in the year 2000. So we've gone quarter of a century with our measles elimination status. We almost lost that in 2019 when this large outbreak that I referred to earlier in New York State and New York City almost extended beyond 12 months. It was just shy of 12 months. It's hard to say right now whether whether this outbreak is going to continue for 12 months. It started in January, so we have a ways to go. I hope not. I hope that is not the case, that we can get a handle on this outbreak through increasing vaccination coverage, but it does remain a threat. And we potentially could lose our measles elimination status if this continues the way it has.
Great. Thank you so much. Here's a question for you, Dr. Durbin, from Jude Jaffe Block with NPR. We are now at the 5-year anniversary of the start of the COVID pandemic. What have we learned in that time about how public health experts can more effectively communicate with the public about vaccines?
That's a great question. I think the big point that I would say is we've learned we have to do better. I was talking with someone just the other day and think back to 4 years ago. Vaccines had just come out for COVID and people were fighting so hard to find access to those vaccines. I had friends calling, 5 different pharmacies trying to gain access to the vaccine. And then probably less than 9 months later, we started to see this vaccine hesitancy and people resisting. And I think part of it was our messaging was just not very good. We had wonderful efficacy, greater than 95% efficacy against what we call symptomatic COVID by these vaccines, but that was just looking at 2 months after you received the vaccine, and people thought that was going to last forever, that they were never going to get COVID again. And we know that that's just not right. We did a very poor job of really talking about what vaccines do, how they work, and what to expect. For instance, we know that we cannot expect vaccines to prevent an infection, meaning prevent necessarily the bug getting in for the rest of your life. It's not a realistic expectation. Vaccines are designed to prevent hospitalization and to prevent death. That's their high-level goal. We may not necessarily be able to, as I said, prevent infection or prevent, for instance, somebody getting a cough, a runny nose, a headache, even a low-grade fever from COVID. But we know that these vaccines prevent hospitalization and they prevent death. And that's really the important goal. And I think as public health practitioners, we just did not do a good job. We were very excited about how well these vaccines were working, the potential of these vaccines. But I do think we have to do a better job really talking to people about why we vaccinate, what we can expect from vaccination, side effects of vaccines, if there are side effects, and what it means in terms of durability. And as Bill referenced earlier, there's some vaccines, and a lot of it depends on the type of vaccine that you're getting. And what I mean by that is how that vaccine is made, whether it's just a part of a bacteria like a protein, which is tetanus, a tetanus toxoid, or whether it's a vaccine like measles, which is a live attenuated vaccine. We know live attenuated vaccines in general provide much longer protection, possibly even lifelong protection against symptomatic illness or certainly against hospitalization and death. Other vaccines, you need booster doses. And I think we've seen that with the change of COVID. And I think that's something we probably could have expected. I mean, we knew even before the COVID vaccine was licensed that we had moved through several different iterations. We had Alpha, we had Beta, we had Delta, then we had Omicron. So really trying to educate the public in a way that, talk to them in a way that they can understand so that our expectations and their expectations are aligned. We're on the same page and we've built a trust between the public and the public health practitioner.
Great. And a follow-up somewhat to that, Dr. Durbin, about how vaccines are made. This is a question from Tom Howell with the Washington Times. Have you seen any signs the new administration is having a chilling effect on research into mRNA vaccines? If so, what are you seeing?
Absolutely. There's threats of grants being completely canceled if they're either developing mRNA vaccines or studying mRNA vaccines. I have colleagues who are reluctant to submit grants that actually use the term mRNA vaccine because they're concerned they won't be funded. It's a chilling effect. It really is. mRNA vaccines have great potential. Like everything else, they're not the silver bullet that we may have thought at the beginning, but they do make it, they're a wonderful platform for vaccines because they're rapidly, we can make a new vaccine very rapidly using mRNA technology. We can do that more rapidly than we can with other types of vaccines, such as live vaccines or even subunit protein vaccines, like the tetanus toxoid or whatever. These vaccines can be developed very quickly. We know the platform is safe. We know that they're very effective, at least, in the short term for preventing illness and in the long term for preventing hospitalization and severe disease. So I do think it's chilling. I think it's taking one of our most effective tools out of the toolbox. And I think that will be bad for public health.
Great. And a follow on for you, Dr. Durbin, tackling some of these diseases, they really are capital intensive based on the realities of inflation trends globally. What's the way out for poor families, especially in the areas where the cost of medicines is high? This is Apollonia Adeyemi with New Telegraph in Nigeria.
That's a great question. I think we really learned this again from the COVID pandemic, where we saw vaccine nationalism and we saw poor access to different vaccines in low and middle income countries. And really the answer is we need more manufacturers. We need manufacturers in places like Nigeria, in low middle income countries, in Africa, in Asia, to help combat the lack or the restricted supply of vaccines that we have. I think that's very important, and I know that there are global efforts to increase vaccine production in Africa and in Asia to make those vaccines available at a lower cost. I want to emphasize that vaccines are one of the most cost-effective public health tools that we have. They're relatively inexpensive, and one of the reasons that we've had a little bit of difficulty, I think, getting more companies involved is because they don't make a lot of money for these companies. It's, you give limited doses of vaccines, but they're so important for public health. And as I said, they're one of the most cost-effective interventions we can do.
Great, thank you. Building on that, for you, Dr. Moss, a question from Susan Morse with HIMSS, Healthcare Finance News. Do you have concerns about vaccine policy given the HHS Secretary's controversial stance on vaccines?
Yes, and this is a big concern for many of us in the vaccine community. As Anna said in her opening remarks, immunization can be a victim of its own success and undermines itself because we no longer see those diseases. And so I think, and I'll use this current measles outbreak as an example. The messaging should be very clear. That the way we prevent measles is through measles vaccination, and the way we're going to stop this outbreak is through increasing measles vaccine coverage, making vaccines available, and talking to people and communities about the value of measles vaccine. We're not getting that clear and simple messaging, and we're getting more muddied messaging from the federal government, and about alternative therapies, as we talked about earlier, which do not prevent measles. I am concerned that we're going to see an undercutting of what has been a highly successful immunization program here in the United States. And so the combination of undermining confidence in vaccines that will lead to decreased vaccine coverage here in the United States and a withdrawal from the World Health Organization and other global organizations that are combating vaccine preventable diseases overseas, we are setting ourselves up for larger and more frequent outbreaks of these vaccine preventable diseases that will be really tragic.
Great, thank you. So we have time for one last short question from Tori Whitaker Martinez with Infection Control Today for you, Dr. Moss. I have heard concerns about tuberculosis along with measles. What should physicians and infection prevention healthcare workers tell their patients and staff?
Yeah, so tuberculosis is a very different beast than measles. It's a complex infection. People can be infected and asymptomatic and go undetected. And we don't have a good vaccine against tuberculosis. There is concern that with decreasing funding from the U.S. government, for global public health programs, including programs that combat tuberculosis, that we're going to see more tuberculosis globally. And again, we're at risk for more cases here in the United States.
Great. Thank you so much. Thank you to both of you for your insightful answers. We will email the links to the resources mentioned today and shared in the chat. We weren't able to get to everyone's questions, but if you would like to speak with one of our experts, please contact us for follow-up. And with that, I'd like to say thank you again to everyone for joining us today.
Thank you.